Of all the forms of inequality, injustice in health is the most shocking and inhuman. In the United Kingdom, by the beginning of the 20th century, the poor health of the working classes and the inadequacy of the poor law were the subject of growing concern. In the election of 1911, the Liberal government proposed a national insurance against sickness and disablement scheme. On March 6, 1911, Beatrice Webb, the social reformer, wrote in her diary, "What we are trying to achieve is to direct the sickness insurance scheme into a big reconstruction of public health." It was to be more than 30 years before her wishes were achieved with foundation of the National Health Service. Many people have died and many have suffered not because the knowledge was not there, but because they did not have access to it. It was this situation that the National Health Service was intended to put right. The question which arises is how successful has the National Health Service been in achieving these aims? In 1979, the Royal Commission on the National Health Service, chaired by Sir Alec Mareeson, reported that the special needs of patients who come from ethnic minorities require sensitive handling by the National Health Service. Problems which emerged in minority communities in the United Kingdom: high stillbirth and perinatal mortality rates in South Asian women, diabetes in the Afro-Caribbean community, delays in management and poorer outcomes in South Asians with coronary artery disease. In 1993, Stephen Lawrence, a black teenager, was murdered whilst waiting for a bus in London. The inadequate investigation by the Metropolitan Police led to a public inquiry conducted by Sir William Macpherson. The report concluded that the police were institutionally racist. Institutional racism is crystallized by Macpherson: the collective failure of an organization to provide an appropriate and professional service to people because of their color, culture, or ethnic origin. It can be seen or detected in processes, attitudes and behavior which amount to discrimination through unwitting prejudice, ignorance, thoughtlessness and racist stereotyping which disadvantage minority ethnic people. In 1999, Joe Collier published a paper in the British Medical Journal which recognized that institutional racism was a problem within the National Health Service. Institutional racism and the care of patients with chronic gastrointestinal disorders. In this review, the care of patients within the NHS will be considered as an exemplar of disparate levels of care according to ethnicity. The conditions considered will be ulcerative colitis, Crohn's disease, achalasia, celiac disease. Leicester has a significant South Asian population. Studies on incidence of ulcerative colitis, Crohn's disease, celiac disease and achalasia had been conducted in Leicester prior to studies on access to treatment. Inflammatory bowel disease. Ulcerative colitis. 70 newly diagnosed patients were followed for a decade. South Asian patients were significantly less likely to see a consultant, more likely to be admitted to hospital, more likely to be discharged from outpatient hospital follow-up, undergo fewer investigations. In addition, there was a trend towards them being less likely to be entered into a colonoscopy surveillance program. Crohn's disease. A retrospective study of biologic therapy for Crohn's disease over a 4-year period based on a clinical register of treatment. Of 139 patients, only 13 were South Asian. With correction for both population size and disease prevalence, the expected number of cases was between 33 and 52. The difference in access to biologic therapy between observed and expected was significant. A retrospective study of access to biologic therapy for Crohn's disease across 9 National Health Service trusts showed significantly lower levels of access to biologic therapy by South Asians in 3. The study used data supplied by the trusts through a Freedom of Information request. The trusts with lower levels of access were Pennine Acute Hospitals National Health Service Trust, Barking, Havering and Redbridge University Hospitals National Health Service Trust, University Hospitals of Leicester National Health Service Trust, ulcerative colitis and Crohn's disease. A later retrospective study of access to biologic therapy for inflammatory bowel disease across 10 National Health Service trusts showed significantly lower levels of access to biologic therapy for patients who were South Asian, Afro-Caribbean, Eastern European. An extensive study using Freedom of Information data was undertaken for the period 2015 to 2019 to assess whether there was evidence of disparate levels of hospital admission for inflammatory bowel disease for South Asian patients across 12 National Health Service trusts in England and 2 health boards in Scotland. Disparate levels of admission were widespread in England and Scotland. Health units in Wales and Northern Ireland did not collect data on ethnicity. Achalasia. Using Freedom of Information data, the approach to treatment of achalasia in 13 trusts with significant South Asian populations was investigated. South Asian patients received a different pattern of treatment to their white British counterparts and were significantly more likely to have a POEM procedure in inexperienced centers. The study also demonstrated that different patterns of treatment were not linked to levels of social deprivation. Coeliac disease. 10 National Health Service trusts with significant Punjabi populations were asked to provide details and/or samples of Punjabi literature on celiac disease, group counseling sessions and lectures, as well as individual counseling sessions and what provisions were made for them to be in Punjabi. Comparable data with regards to white British and Polish patients were requested. Punjabi and Polish patients were significantly less likely to be offered literature in their own language or to attend group counseling sessions or lectures. Individual counseling was comparable, but in the case of Punjabi and Polish patients this would be through an interpreter. Achieving change. There are clear differences in the pathways of access to care for chronic gastrointestinal diseases for minority groups compared to the white British population. However, black and ethnic minority populations have long been blamed as the cause of their own ill health. The first step is to acknowledge the problem. National Health Service Constitution. Legal duties require National Health Service England and each clinical commissioning group to have regard to the need to reduce inequalities in access to health services and the outcomes achieved for patients. It has a wider social duty to promote equality through the services it provides, and to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. Responsible organizations. National Health Service Improvement. Care Quality Commission. Equality and Human Rights Commission. National Health Service Trust Boards. Clinical Commissioning Groups. Health and Wellbeing Boards. There have been no reports of responsible organizations ever taking action on the basis of ethnic or religious discrimination. As Salway et al. Have pointed out, this is often due to managers and teams not considering that tackling ethnic healthcare inequities is part and parcel of their job. None of the 3 trusts identified in the initial multi-center study of biologic therapy in Crohn's disease took any action in response to their discriminatory practice in the year subsequent to the study. Neither did the clinical commissioning groups nor health and well-being boards, National Health Service Improvement, the Care Quality Commission nor the Equality and Human Rights Commission. An unpublished study of the composition of National Health Service Trust Boards showed no difference in the proportion of members who were of Asian ethnicity when discriminating and non-discriminating units were compared. In both types of units, executive officers from an Asian background were in a significantly lower proportion than non-executives. The best hope for addressing health inequalities is through a new statutory requirement for regular reporting of differences in management and outcomes by ethnicity for a range of named diseases. Trusts and clinical commissioning groups would be required to provide such data annually. Its mode of collection and validity would be assessed by an independent commissioner who would publish the results of their findings. Executive boards and management of failing organizations would be held legally responsible for any inaction.